Welcome, everybody. I hope you've enjoyed the conversation already. My name is David Balat. I'm the director for Right on Healthcare, as well as the executive director for Free to Care. I'm really excited about the conversation that we're going to be having today. We've got two folks that are really experts in the discussion that we're about to have. A little bit about my background that some of you may or may not know. Prior to my work in healthcare policy, I was a hospital executive and CEO for nearly 2 decades. A good stint of that career was in physician-owned hospitals, and I can tell you from personal experience from my administrative perspective, is that the quality was outstanding. The customer service was far away better than it was in the other forms of hospitals that I served in. Our infection rates were among the lowest in the hospitals that I spent time in. And of course, the affordability was better. Many of the arguments that we hear against physician-led hospitals is that, well, doctors are just going to run up the bill. Isn't it interesting now that since Obamacare, we've seen more and more hospitals now try to control the doctor's pen so that they are able to do exactly the thing that they complained about in the very beginning, to push against physician-owned and physician-led hospitals. So again, I'm really pleased to be here. I'm thankful to be moderating this. I'd like to introduce our panelists, and we're going to jump right into it. Let me start with you, Dr. Liss, if I may. Dr. Frederic Liss has been with the Rothman Orthopedic Institute since 2013 and has been practicing hand surgery in the western suburbs of Philadelphia since 1995. He's the co-founder of Physicians Care Surgical Hospital and treats patients there at Physician Care ASC, Powley Hospital, Powley Surgery Center, and Surgery Center at Limerick. I hope I was saying that correctly. Dr. Liss is a clinical associate professor of orthopedic surgery at the Sidney Kimmel Medical College at Thomas Jefferson. In 1992, he completed a fellowship in hand surgery at the Hospital for Joint Disease Orthopedic Institute in New York City. Prior thereto, Dr. Liss completed his residency in orthopedic surgery at Temple University Hospital and his internship at Pennsylvania Hospital after completing medical school at Temple University School of Medicine. Dr. Liss is a fellow of the American Academy of Orthopedic Surgery and serves as the secretary of that organization's OrthoPAC. He's also the president of Physician Hospitals of America, who is a co-sponsor of this event, a fellow and board member of the Pennsylvania Orthopedic Society, and serves as a member of the Medical Alumni Board of Directors of the Lewis Katz School of Medicine Medical at Temple University. Dr. Liss, thank you so much for being here. Our other panelists, Dr. Robert Moffit, and as he said, not that kind of doctor, is a senior research fellow in the Center for Health and Welfare Policy at the Heritage Foundation in Washington, D.C. Dr. Moffit has long specialized in healthcare and entitlement programs, especially Medicare. He brings to the reform effort his government experience as a senior official of the U.S. Department of Health and Human Services, HHS, and the Office of Personnel Management during the Reagan administration. To achieve affordable healthcare, Dr. Moffit has urged policymakers to give Americans more direct control over their healthcare dollars. I think that's everybody everybody on this call anyways, advocating for that. To eliminate barriers, that's why we're here today, and to personalize choice in healthcare options and to allow citizens to own private health plans. At the same time, he believes policymakers should limit government intervention in what should be a much freer and far more competitive healthcare market and work to restore the traditional doctor-patient relationship. And we thank you for that. He's the co-author of Why Obamacare is Wrong for America, which hit the number 4 on Washington Post's bestseller list. Thank you both, gentlemen, very much for being here today. I certainly appreciate it. I'd like to start the conversation off with, and Dr. Liss, maybe we could start with you and then go to Dr. Moffit for the same question. Why are we here today? Why are we having this issue? Why can physicians not own hospitals?
Well, it's a complex answer, but basically it's an anti-competitive issue. I think that the status quo in the United States has been to support monolithic hospital systems, very large systems that combat for, they fight for control of the healthcare dollar, which is something that has become really inherent in the system of healthcare that we have. And it's not always guided or directed towards what's best for patients. And physicians about 20 plus years ago began to develop what were called specialty hospitals, which were offensive to the big hospital systems because they saw it as competition. And it started a long cascade of anti-competitive pushback by the big organizations like the American Hospital Association, the Federation of Hospitals, which represent the not-for-profits and the for-profit hospitals respectively. And so what we've learned through the many years of evolution of physician-owned hospitals is that we know how to do it better. Nobody knows, and nobody is more aligned with the goals and the outcomes of patients than the doctor themselves with the patients. And so, we've done a very good job of, in an innovative fashion, creating a lower cost, higher quality healthcare system within a system that we've fought tooth and nail to remain relevant to American patients. And, we fight a very large lobby. So the reason why we're here is because, we believe at the PHA, and I want to make one little correction to your intro to me. We're now called Physician-Led Healthcare for America because we represent innovative physicians in all walks of life, not just about hospitals, although the hospital issue is our main agenda item, and it remains that and will so. But, we believe that the innovation of physicians, together with knowing what it is that their patients need, really is an important piece that needs to be integrated into the healthcare system that exists, not excluded, not discriminated against, but welcomed as an alternative to create what Dr. Moffit believes in, which is competition, healthy competition, and patient-driven healthcare. So that's really, in a summary, in my mind, why we're here and what our drive is at the PHA and our belief in physician-led healthcare.
Thank you, Dr. Liss, and I apologize for the mistake on the.
Oh, that's okay. Well, it's our new branding, so we're still rolling it out.
Excellent, Dr. Moffit.
Can you hear me now? Can you hear me now?
Yes.
Okay. Well, we're here because the American healthcare system, as big as it is, almost 20% of the gross domestic product of the United States, is one of the least competitive sectors of the American economy. And that is nowhere more true than in the hospital sector. The Federal Trade Commission, which monitors these things very carefully, has indicated that basically 90% of Americans live in non-competitive hospital markets. And the evidence is overwhelming, and I'm talking about the professional literature, primarily by healthcare economists and political scientists such as myself. The evidence is overwhelming that what has happened is that we have seen less and less competition, but at the same time, higher and higher costs. And on this issue, I can tell anybody who wants to listen to it, I mean, either here or in Congress or anyplace else, there is an enormous bipartisan consensus among healthcare economists on this fact, which is that non-competitive markets drive up healthcare costs, they reduce the quality of service to patients, and they limit the choice and competition that is essential for productivity in any other sector of the economy. The absurdity of the current law on the face of it is quite incredible, that Congress, under the Affordable Care Act, would actually increase barriers to care, to specialization in care delivery. If you just think about it for a second, David, in every advanced industrial economy of the world, in every sector of the economy, specialization increases productivity. Specialization combined with competition promotes innovation, which lowers costs and raises quality in any other sector of the economy. We do not have that happening here. And so when the Affordable Care Act basically prevented any kind of reimbursement by Medicare and Medicaid of physician specialty hospitals, it was a triumph, not of anything that was rational, but it was a triumph of special interest politics at the expense of the public. And it's a disaster, and we've got to reverse it. And once again, it's not my personal opinion. It is the founding, it is information that is basically available to anybody who wants to look at the professional literature, which is fat and getting fatter on the truth of that proposition.
Dr. Moffit, a follow-up question for you. Why is it today that physicians cannot own hospitals? For those that don't know, why is that even a thing today? We know about certificate of need in individual states, but on the federal level, why can physicians not own hospitals?
Well, because right now the biggest major biggest payer in our healthcare system is the $926 billion Medicare program. And if you take all the revenues out of Medicare, if you take the Medicare revenues away from doctors and you take them away from independent physician owned hospitals, they can't really compete. So it's not worth, the expansion. And what happened in 2010 is Congress simply said, look, these hospitals will no longer get Medicare reimbursement. Well, that's a tremendous loss of revenue. It's just basically dollars and cents. The government has imposed a limitation on revenues for a whole class of medical providers. It's hard to imagine anything that is more incompetent as a matter of public policy, except if you take the position that it's a deliberate attempt to basically line the pockets of large hospital corporations.
And for those in the audience, I think it's important for you all to recognize you can't be enrolled in Medicaid unless you are enrolled in Medicare. So if you're not going to be authorized by the Medicare program, then you cannot have access to Medicaid patients either. On average, throughout the country, Medicare and Medicaid revenues to the hospitals are
Enormous.
right around 40%.
Yeah.
So it's a significant piece of the revenue. The other benefit of Medicare is that they typically pay within 10 to 15 days, which is critically important to a hospital's bottom line, whereas it's 30, 40, sometimes 60 days from private insurance. Dr. Liss, so you all on your website, you have some really interesting videos that provide some great information. Talk to me a little bit about this lack of competition that has been created by these hospitals, and what is that? What are the noticeable problems that have occurred because of this tactic on the part of the AHA and their members?
Okay, just to add to what Dr. Moffit said, so back in 2010, when the Affordable Care Act was approved, the big lobbies negotiated a deal with the Obama administration to give a little bit on what Obama wanted for the Healthcare Act that they instituted. And in return, they had Section 6001 installed into the Affordable Care Act, which said that any existing physician-owned hospital having any ownership whatsoever by a practicing physician could no longer expand, not one single bed. So in other words, my hospital that I founded has 12 inpatient beds and has 5 operating rooms. We are not allowed to add a single bed to the system. So if we did that, we would violate the Medicare law and we would lose our Medicare reimbursement. So going forward, the hospitals that were in place that were owned by physicians are able to exist, and we do get reimbursed by Medicare and we see Medicare patients, but we're not allowed to expand. And you can imagine, if you were the best restaurant in town and you were told you can't set another table, even though the demand was high, what would happen? And this is exactly what the problem that's happened. So there's another level to talk about here, and that is that, a physician, as a doctor, as a surgeon, I don't want to just serve one sector of the society. I want to practice and be available to everybody who comes to my office. And if I can't expand and continue to serve the Medicare population, well, then they're going to lose access to that care, because naturally, the only way a business can thrive is to grow. It doesn't, if you stay stationary, you're going to wither on the vine, which was exactly the negotiated plan that the big lobbies had for us, which was, we want to eliminate this potential for growth of these hospitals because they're better than we are in many ways. They take what they think is their business away from them. So, what it's done is it's made it very difficult for us. For example, I'll give an example of what happens. In our hospital, we do about 500 surgeries a month, maybe 600, and about 200 of them are inpatient cases. But with 12 beds, you can imagine that we have to jockey patients coming in and out in order to have capacity to handle the volume that is demanded of our services. So we have to expend extra effort just to provide services to those Medicare and private payer patients to be able to have a bed available after their major surgery. So that presents it presents an obstruction to being able to provide service. And, that in and of itself is preposterous. I agree with Dr. Moffit on that. I mean, it just shouldn't be in this country. It's not like we're not doing anything illegal. We're doing a very good job at what we do. My hospital in the first 2 years of its existence was number 5 on the Medicare HCAP list for the United States of America. I mean, we were doing such a great job. But now what they've done is, here's another anti-competitive thing. The AHA pushed back on Medicare and made it so that the star rating system no longer applies to more than half of the physician-owned hospitals. They changed the rules. Why? So that we could not get any press through the government to say, yes, we're good, so that patients, it's not transparent. We've lost the transparency of healthcare. And that's another issue that we work on very hard at PHA and within the physician-led healthcare industry is we want transparency. We want patients to drive healthcare. We want a patient to be able to know that when they're going to have a hip replacement or they're going to have a heart surgery, that they can look at the quality of a hospital, the cost of where they're going, to know what it's going to cost for them and in and out of their pocket, and to know who the surgeons and the doctors are that are caring for and the ratings and the quality that they have there. But this kind of behavior that's happened and this whole movement that's happened, 10 years ago, actually started long before that. There were many attempts to eliminate the right for physicians to own hospitals. And the final thing I'll say on this is they've not only limited the existing hospitals, but they've made it so it's impossible for a physician to own a hospital going forward. We cannot start de novo hospitals and have a Medicare contract. They can be private payers and all that. And I always say to the legislators when I meet with them, it's like, be careful what you wish for, because what you're doing is creating a tiered system where, only the people who have healthcare outside of Medicare are going to be able to get access to this kind of care. Do you really want to do that? So it's really put a limitation on the access to people who want to, and we love Medicare patients, not because they pay in 2 weeks, but because they're an integral part of my practice. I've been in practice for 30 plus years, and those patients are my age now. I'm 62. I mean, these are people who want to come to me. And if I have trouble getting them into our facility, I have to take them to another facility. And that's not what they want. And I think everybody deserves to be able to choose what they want. And that's really the big issue here that's been created by this opposition by the big lobbies.
Yeah, without question. And I think it bears repeating. Hospitals, the AHA, they came and said that there was too much power for the physician to both be the physicians admitting the patients and owning the hospitals themselves. Well, what have we seen over the last decade and more is not only the hospitals starting and owning insurance companies, they're employing physicians to the tune of nearly 70% of all physicians are employed by hospitals today. So they're vertically integrated, and they've done the exact same thing that they lobbied against. Not that physicians were necessarily doing anything incorrect, but all of the horror stories that they portrayed, they themselves were essentially projecting because they are those bad actors in large part today.
Yeah, well, let me add to that briefly, because that's a very, very important point. So when the physician hospital industry began, the big claim by the big lobbies was that we were cherry picking, taking the best patients away. So what's happened now is with the ownership and the acquisition by big systems of doctors and practices, et cetera, what they've done is they've found a way with their lawyers to make it so that it's legal for them to insist upon their physicians that are owned by their practices or owned by the systems to demand that they refer inside of their own systems.
Yeah.
I'll take a practice like mine, the Rothman Orthopedic Institute. We work together with healthcare systems in the region. We take many of our patients to those hospitals, not because we have to, but because we think it's the best served location for them for various reasons. So we're able to make decisions together with our patients to give them the safest, best, lowest cost healthcare. And yet the other side of the coin is they're now saying exactly what you said, which is we're not going to let our patients go to any other facilities. We're going to hold them hostage within our systems and not allow them the choice to go where they want to, or where it may be lower cost, higher quality, closer to home. This is what I want, whatever the reason is. And that is, it's enigmatic when you, and at its face value, but when you really dig into it, you realize that it's a very calculated maneuver by the healthcare systems to make sure that there's no competition. And it's hurting healthcare, as Dr. Moffit said. It's absolutely driving costs up and not allowing, for the competition that needs to happen. And one final thing on that is that, we don't think that physician-owned hospitals are the answer to all healthcare. We think it needs to be integrated, and there needs to be this competition and ability to raise the bar. The first thing that happened when we built our hospital, the local hospitals created orthopedic and specialty centers in their facilities with the kind of infrastructure that we had to give better quality care. And we love that. We thought that was the greatest compliment to our existence, even though they fought tooth and nail for us. So, it's not that also, it's not one size fits all. It is, there needs to be creative, impetus for all of us to just continue to do better at what we're doing. That's really the part that really is being hindered by these limitations.
I appreciate that. Thank you. Dr. Moffit, I'd like to pick your brain on an issue. You've written extensively. I loved your research that came out here. I think it was earlier this year.
Yeah.
On this topic. It's a little bit of a history lesson that you're going to be really familiar with. We saw a lot of hospitals shut down in the 80s, and the response federally was to create a new classification of critical access hospitals. And that did a pretty good job of stalling that decline and loss of hospitals. Well, here we're having the same issue again. We're starting to see more and more hospital closures. And then what we're seeing at the federal level is this new classification, rural emergency hospitals. And I found it interesting that CMS is, although this isn't a traditional hospital, it's a rural emergency hospital. CMS is saying, yeah, it's okay for physicians to own these types of facilities. Aren't they being, what are they saying? Are they being contradictory? Are they, how are we to think about this? Are they leaning more towards allowing for physician-owned and physician-led?
No, I don't. Let me put it this way, and again, I know this sounds a bit cynical, but I don't think that there is in many cases, there's not a great deal of strategic thought about all of these things. I mean, sometimes it's nothing more than a reflection of the political pressures at the moment and the response of the administration or Congress to those political pressures. Yes, if physicians can own, we've got a problem. Everybody knows this. I think most of the people listening to this probably know this is true. We have a problem with rural health in America in terms of access, in many cases, to healthcare in areas of the country where you don't have the same population density. It's even true in states where you have a very high degree of population density. I have personal experience with this. I was chairman of the Maryland Healthcare Commission, appointed by Governor Hogan, and believe it or not, confirmed unanimously by the Democratic State Senate. But in any event, looking at Maryland, we have 48 hospitals, acute care hospitals. But on the eastern shore of Maryland, which is a rural area, we have access issues that people are very, very concerned about. Getting a hospitalization, and some of these hospitals are under tremendous pressure to stay open. So I'm not surprised. I mean, somebody would say, well, look, we're talking about something very serious here, the ability of people to get the emergency care that they need, or to get the acute care that they need when they need it, instead of traveling 50 or 60 miles to another, location, that they would do this. But the truth of the matter is, David, is that we don't have a rational policy coming out of Washington on this issue. The rational policy is there should be no difference. There should be a level playing field, regardless of whether you're talking about a rural area or an urban area, because you're not, the principle is simple. If you believe that the market is an efficient mechanism to produce and distribute goods and services at the lowest possible cost and the highest possible quality, there should not be this kind of government decision-making, which basically picks winners and losers at the expense of the public. It's that simple.
Let's add to that a little bit of a clinical piece to it. So these rural emergency hospitals sounds great. We're gonna provide service. We're gonna let doctors come in and own those things, but we're gonna limit it, and you can't have an acute care bed in it. Can you imagine what happens? We're trying to stop people from having to travel 50, 60 miles from a rural area to get healthcare. When you come in and you have some sort of an acute emergency, a trauma, or one of these types of things where you really need care right there and you can't be transferred, it really doesn't make any sense to me to create a system where you can have emergency rooms, basically, big emergency rooms, emergency care facilities, when we know that one of the most expensive and wasteful areas in healthcare is emergency rooms. Patients go to ERs for reasons that they don't really need to go. And then the ones who come in, if they can't get care in that facility, it's absurd to think that that's going to end up being a solution to the problem in rural healthcare. So what I would propose, and I think it's consistent with what Dr. Moffit is saying, is we ought to open it up and allow physicians to go into these areas where they can have traction, own and run a hospital, and create great healthcare, because it's going to do two things. One, it's going to provide super high quality, low cost care in an area. And secondly, most importantly, it's going to attract really good physicians to live in areas where they otherwise wouldn't, because they can't get access to the equipment that they want, right, or the type of care model that they want. So we were just made aware of recently a gentleman who was stuck in a hospital in rural New Hampshire, and we were trying to get him into Mary Hitchcock, which is Dartmouth's facility, because the hospital where he was didn't have the equipment that he needed. And I made the case to the folks I was talking to that the reason why the equipment doesn't exist there is because you don't have the doctors there who demand it and who need it, because you don't have the specialists. So to me, it makes a lot of sense to inspire growth and care and provision of really good services to rural residents who deserve that. And it's not just poor people. It's people who live in rural areas. It's a very good cross section of society, but we have to provide healthcare in those areas. And the big hospitals don't want to go in there because they don't make a killing there. They can't make their money there, so they just have been closing them up. Why not allow physicians to take that risk to go in and provide the kind of services that are needed? Doing it with a rural emergency hospital where you can't have an acute care bed, to me, is a great opening for physicians to be able to start, but it is not a solution. And I agree, it's not a cogent policy that's been put out. It doesn't make any sense to me.
I posted the video that's on your website, Dr. Liss, which is excellent. And I encourage everybody to click on that. One of the quotes that I found really interesting, and Dr. Moffit had shared another statistic, and I'd invite you to share it with the group again. But on the video, it said by 2017, in most markets, a single hospital system had more than 50% market share of discharges. A single hospital system. That's as anti-competitive as it gets.
Yes. It's a very common problem. And even where you have a lot of hospitals, I just mentioned, the state of Maryland, you have 48 acute care hospitals. The problem is those are 48 acute care hospitals are owned by 4 hospital corporations. So that's basically it. Yep. So you basically have these large oligopolies that exist, all over the country. And, as I mentioned earlier, if I didn't mention, I'll mention again, you have the Federal Trade Commission that has been looking at this, and God love them. They're being very, very straight and very fair about this. roughly 90% of Americans are living in non-competitive hospital markets. And the evidence, the evidence, the professional literature, everybody from the Robert Wood Johnson Foundation to the Center for Medicare and Medicaid Services to top economists at Brookings Institution like Martin Gaynor has pointed out that this consolidation has led to very substantial price increases and has not in any way really improved the quality or service to patients. And so we've got to reverse this. Look, the opening up the market to physician-owned hospitals is one major way to start to reverse this awful trend. But there are other things that we must do. And I'll just mention two other things that I think are really critical here. One of the great things that the Trump administration proposed, and they did it through regulation, was to introduce, on a regulatory basis, introduce hospital price transparency. And to his credit, the President Biden has endorsed this regulatory change. Trump has actually gone further than that and also proposed a health insurance market price transparency rule. This is something that is also very critical. Most Americans have, especially today, given the inflation that we've got, most Americans know, the cost of a gallon of gasoline. But despite the fact that we have basically 20% or 20 cents out of every dollar that we spend in the United States on healthcare, most Americans have absolutely no idea what common medical procedures cost. And if you think about this, just think about it, it doesn't make any sense, does it? But because Medicare and healthcare generally is such a large portion of the American economy, but people have no idea. I mean, they have no idea what things cost. Now, one of the things that we did in Maryland, and it was a very big step in the right direction, is to say for shoppable medical procedures, the kind of thing that Dr. Liss does, orthopedic type surgery, hip replacements, knee replacements, vaginal delivery is an important area. People are, this is not an emergency thing. This is not something where you were, sweating blood and figuring out, how am I going to make a decision? These are very shoppable decisions. You have a chance to sit down with your primary care physician or your specialist and say, look, who does the best job here? What we did is we took about we started with 4 or 5 medical procedures that are very shoppable. And what we decided to do was to say, this is going to be the cost to the consumer on average. And not only that, we tied that cost to the consumer with a quality metric so that they would recognize, that if you go to this hospital, not only is it this cost, but the outcomes are better. This kind of transparency can help to drive increased quality in the system. Now, what I think we need to do beyond repealing the Obamacare restriction on physician ownership of these hospitals, especially specialty hospitals, what we need to do is we need to codify these transparency rules. So, the next administration or whoever, whatever happens at CMS, it doesn't go away. We have to start codifying these rules and establishing price transparency, because if people do not know the price of anything, you can't have a functioning market. It's that simple. Adam Smith, 1776, The Wealth of Nations. Prices give signals. They determine what things actually cost. And people are in the dark today about, what things actually cost in healthcare. But there's no divinely ordained darkness here. It's just the fact that our public policies do not reflect a commitment to the market. And if we were to change that public policy, people would have an idea of what things cost, and they would be able to make the rational transactions and I'm talking about non-emergency services here, rational transactions that should drive the system and would improve the quality of care in that system.
I'd like to add a couple of things. I included a link to Dr. Moffit's research in the chat. 2 other initiatives or solutions or proposals that he makes are outstanding ones. And if you haven't read it, I would encourage everybody to read it. But the two other things that you talk about are encourage state officials to review, reform, and or repeal. Maybe we should just say repeal certificate of need laws.
Oh, yes.
Yes. Because even with this federal repeal of the moratorium in the ACA, you're still contending with that in a number of states.
Oh, yeah.
Dr.
35
Liss.
states altogether.
How many?
35.
35. I mean, the majority of the country.
Yeah.
And then the other one, which is a big deal, is includes site neutrality in Medicare payments.
Oh, yes. 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 Today, under current Medicare law, if you get medical service provided to you in a hospital setting, the Medicare reimbursement is higher. So obviously, right? Obviously, the hospitals are going to be, that's where you're going to get care. If you decided to say, in effect, if the Congress were to say, look, yes, we're going to pay you for the procedure. We're going to pay you for the medical service that you are delivering, whether you deliver that service in a hospital, a physician's office, a clinic, or a group health facility, it doesn't make any difference. You level the playing field. Once you start leveling the playing field, you get real competition. Now that will happen within the Medicare program, but here's the important point. Because Medicare is so big and it has such an enormous influence on the rest of the private sector healthcare financing and delivery, once you do that, you start to basically create a spillover effect within the private market itself. And a level playing field is exactly what we need in this area. And Congress can do that. Now, there has been certain, once again, the Trump administration made some moves on a regulatory basis to do this, but Congress has to go much further. And I'm happy to say there seems to be real interest on a bipartisan basis on doing this. There's a congresswoman from Indiana, Congresswoman Victoria Spartz, who's introduced legislation to start to promote price transparency. That's the beginning. But other members of Congress, I think, are going to find this to be a very attractive policy. Hopefully, when we get a change in Congress, we'll be able to enact some of these major changes.
Dr. Liss, I see you nodding your head. Do you have anything to add to all that?
Yeah, I do. I love hearing these things about transparency. Transparency is a big, major issue for us at the PHA. It is an initiative for me. I've gotten to know Marty McCary at Johns Hopkins, who has written a lot about transparency and has made a personal change in his life to work on this issue. And I just had a conversation with him on the phone the other day, and there was a physician-owned hospital in Oklahoma that actually started posting their prices just like that, so that patients knew what it would cost. And who do you think really blew up over it? The payers. They didn't like it. The hospitals, they didn't like it. Why? Because it's anti-competitive to them, because they know that they overcharge and they're not transparent. And the other thing is on site neutrality. Why do you think that exists? Why is there an HOPD rate? Why is there a higher rate for hospitals who do surgery in their surgery centers? Even if it's not on their campus, it could be remote. The reason is because they've lobbied it in so that they can get paid higher for the same services, and it makes no sense whatsoever. So at my hospital, we get paid less in a hospital to do an outpatient procedure that I do, say a carpal tunnel release, than the surgery center across the highway that's owned by, a healthcare system that has an HOPD rate. Makes absolutely no sense. It hurts everybody, and it doesn't inspire any creativity whatsoever, or what we call demand matching. We talk about the term value-based care. We need to find ways to inspire each other to make sure that we are taking patients to the lowest cost center, or you're just going to have people taking them to where they're going to make the most profit. And that's the unfortunate political piece that exists. So transparency and site neutrality are huge. There's another guy out there that I want to give a shout out to that maybe many of you have heard also from Hopkins. His name is Brian Miller.
Oh, yeah.
Brian Miller is a guy who has taken it upon himself to really examine these healthcare policies and do independent work. I know him just because we cross paths and we've talked very much about these issues. And he's done some tremendous independent research that just demonstrates things that we know from Medicare programs. For example, the innovative programs, the DRGs for the Center of Medicare Medicaid has done studies through their programs for total joint replacement. 72% of participating physician-led hospitals produce savings. I mean, we save money for the Medicare system, yet we don't get the acknowledgement on the legislative side to inspire us to continue to do that, to compete, because not only does it lower the cost in our hospitals, but it also inspires the big hospitals to say, we got to do better than this. So there's a political piece, and then there's the regulatory piece. We all are speaking the same way now. And I agree, Dr. Moffit, the Biden administration came out with a consolidation executive order to start working on consolidation. I'm working hard to make sure that the Democrats on the Hill put their money where the president's mouth is and start doing things to make changes. And there is a bipartisan approach now, more than I've seen in 15 years of lobbying on Capitol Hill regarding these things, because the truths are self-evident now. We see it. We all know what it is. And we got to stop telling the emperor that he's got beautiful clothes when he's standing there naked. That's really the bottom line.
Yeah, I want to follow up on a little bit about the business about quality and the and physician-owned hospitals. I mean, as Dr. Liss said at the very, very beginning, David, this issue of restricting physician ownership of hospitals began a long time. A lot of people forget it. Back during the debate on the Medicare Modernization Act of 2003, this issue came up. That passed this was during the second Bush administration, George W. Bush. The issue came up, and when the law was passed, the Medicare Modernization Act was passed, Congress authorized or ordered basically the Center for Medicare and Medicaid Services to do a look at this whole issue of what some of the big hospital chains were saying. Do the physician-owned hospitals, do they cherry pick? Are they contributing positively to the provision of medical care? And the CMS study in 2005, two years later, they produced the study. They made it very clear that there was not this cherry picking on the part of physician hospitals. They weren't taking Medicaid patients and sending them over to these large community-based hospitals. And, this is really critical, because part of what we're dealing with here is a series of mythologies that have developed over time that were, basically became the reason for rent seeking on the part of very, very large corporate interests. In 2015, there was a study undertaken by researchers for the British Medical Journal, and they pointed out that that there was no systematic transfer of patients from these physician-owned hospitals into the Medicaid program. Once again, no cherry picking. And you mentioned Dr. Brian Miller at Hopkins. Dr. Miller has done some of the best work in this area. There was a comprehensive review of the professional literature recently published by the Mercatus Center at George Mason University. And he looked, again, this is a professional review of the literature, review of the professional literature. And what Dr. Miller and his colleagues found was that overwhelmingly doing a systematic review, the physician-owned hospitals provided higher quality care at a lower or comparable cost compared to the general hospitals or the community hospitals. So the evidence is in. If you want to talk about following the science, following the evidence, if you want to talk about evidence-based policy, we have the evidence. Now what we need is the political courage on the part of both Democrats and Republicans to act on the facts and basically ignore the kind of rent seeking that is so common among corporate interests in this country.
Yeah, and a little bit more on that Mercatus Center study at George Mason by Brian Miller. I mean, he threshed out that there, in a range of serious conditions, that people who had their surgery or their care at physician-owned hospitals had a lower in-hospital mortality rate, and that people who experienced they experienced shorter stays, lower risk adjusted complication rates in physician-led hospitals. So it's not just the economics of it, it's also the care of it.
Right.
And I think, having worked inside of hospital systems all my life that were not physician owned, what I know is that when physicians are at the leadership of driving what's going on clinically in a hospital in a meaningful way, the hospitals are better, the satisfaction rates are higher. There have been many studies that have demonstrated this as well. So what we have to do is exactly what you're saying. We have to just look at the data in front of us and respond to what we're seeing, and stop responding to political pressure and just take the risk. I mean, I always say to legislators, what are you afraid of? Are you afraid that the AHA is no longer going to support you? If you do the right thing, they're going to have to support you. They're just living on these banal statements that they've been making, and the folklore that you've alluded to that creates this falsehood about what it is that physician hospitals are doing. So yeah, I can't emphasize enough. I think Brian Miller has done a hell of a job threshing this out. He's an independent practitioner. He works at Hopkins. He's doing great work. And, people like Dr. Moffit and Dr. Miller, and that study that you referred to in the British Medical Journal, that came out of Harvard. I mean, that was a Harvard study by also independent studiers. And we presented that in Congress, and it just, the CBO takes information from their own sources. You cannot provide them with external data and then have them buy it or use it. They only use what's given to them in their own world. And that's also another problem. There's a vacuum that goes on in the data that's used to make decisions inside of Washington. And there's a political piece to it, a big political piece.
Well, thank you, gentlemen. As much as I'd like to get to questions, I have one more question that I think is too crucial to not ask you both while we have you here. But before I get to that, I do want to say I'm in the chat, and I'm coming across Dr. Greenwood and has I'm guessing ownership in family hospital systems. And I went to their website, and they have bundled pricing for their procedures. This is the way it should be. And you're in Austin, I'm in Austin. I need to come visit because more people need to know about this. But gentlemen, thank you guys for being here. I have a very important question. And this question is for the purpose of getting the audience and for those that will see clips of this discussion later. What can we do to help get the message across to affect change in the future? What are the action items that can be done?
Let me start first. I think you should start recognizing that much of the anti-competitive regulatory activity takes place at the state level. I'm talking about certificate of need and various other kinds of restrictions that frankly make no sense, but are baked into state health regulatory policy. So I think state legislators have got to be on the receiving end of citizen activity. With regard to the federal issue, and we're really talking about a couple of big items here. You're talking about the certificate, not the certificate need, but the site neutrality issue, the transparency issue, and of course the Section 6001 of the Affordable Care Act. These are congressional matters. And if members of Congress are told very clearly that bad policy should not be, perpetuated, that seems to be enough. I can't basically, as a member of the Heritage Foundation, I can't basically tell you to lobby Congress on a particular bill or anything like that. But I can say that the current absence of price transparency, including the absence of a federal law governing price transparency, site neutrality in Medicare, and the need to open up the hospital market to specialized care delivery delivered by physicians and frankly others, that should be a number one agenda item for those of us who want to see a much more competitive market. Remember, we live in a healthcare system which is practically 20% of the gross domestic product of the United States, but it is one of the least competitive sectors of the American economy, where people do not know, where people actually have a hard time controlling their own dollars, where they know the cost of anything. And in fact, it's also one of the least competitive sectors of the American economy. Ultimately, that's going to require citizen action. And that means talking to members of Congress.
Dr. Liss?
Well, I agree with everything Dr. Moffit said, and I would say that the 30,000 foot view is, and one of the things that we have as an initiative with the PHA is we want to make this a public issue. I mean, the problem is it stays in the back offices of Congress, and the patients don't really know that they have a say. And I would also say to the doctors on the call, talk to your patients about it. That's what I spend a fair amount of time in my office interacting with patients about, letting them know about it. But we need to publicize what this problem is and realize that we're all on the same team. I mean, one of the philosophies that we have at PHA is we're not in this to beat the AHA. The PHA wants to work together with the government to create solutions that are going to help healthcare. We did it during the pandemic, when we made ourselves available to either treat COVID patients or to take overflow surgeries or overflow care. We did it beautifully. We adapted, we're nimble, and patients realized that and were appreciative. And then what did Congress do? They cut reimbursement to doctors. That was the answer to the pandemic. So, we need to speak about it. We need to, and I would say to patients, don't accept this opacity that happens in healthcare. Argue the bills that you get charged. People go in, they don't have healthcare insurance, and they get charged not the Medicare rate, they get charged some ridiculous charge master rate. And then the hospitals negotiate it down to something that's 4 times Medicare, and then they put somebody into bankruptcy over that. And Marty McCary has made a life's mission out of working with patients to make sure this doesn't happen. The transparency issue is huge. It's complicated and difficult because there's a big force against us. But the only way that's going to happen is through conversation and patients objecting to it and saying this is not acceptable for us in the United States, and talking, yes, to their state legislators and sending, getting linked in with groups like the PHA and those who have a voice, and start talking to Congress and letting them know, just sending emails and saying this is unacceptable. And the more we get to that tipping point, closer to the tipping point, I think the more that our congressional leaders are going to be pushed into a position where they finally have to accept the facts and stop listening to the rhetoric.
It's always helpful to unmute. So what I've heard is in states where you have a certificate of need, work with various groups that are looking to reverse that. Let your legislators know both at the state and the federal level that transparency needs to be a priority. And I'll just, as an aside, I'm about to head to Wisconsin, and we worked very hard to make law the executive order at the federal level here in Texas. We were the first state to make law hospital price transparency, and when you poll it, it's a 90% issue. It was unanimous coming out of every committee in every chamber before the governor signed it, but he got incredible pressure from the hospital association. In talking to the folks in Wisconsin, the hospital association there in Wisconsin is already having meetings at the sheer thought of the fact that this is going to hit their legislature, and it absolutely will. People deserve to know the prices, and that's something that you can be involved in. And then also talking to your House rep and your senators about repealing this moratorium on the physician-owned hospital in the ACA. Are there any bills that are currently good bills that we can support, that we can tell our legislators about?
Well, there's the House bill, and there is a companion Senate bill for repeal. There are, and that's I don't know the numbers of them. Stacy, who may be on the call, could probably tell us those. I'm horrible with legislative bill numbers, but basically, there has been for the last several years an effort internally to propose repeal on the ban on physician-owned hospitals. I also would point out that the the Republicans, who are likely to take control of the House, at least all predictions are, have created a Healthy Futures Task Force, and they included in their agenda items increased competition by eliminating the ban on physician-owned hospital ownership and expansion. So we're seeing, we want our legislators to know that this is an important issue, and there are bills out there that are in the House and in the Senate. The Senate one was sponsored by by Senator Langford from Oklahoma and Senator Roger Marshall from Kansas. And in the House, I believe it's Dr. Burgess from Texas, and Stacy can maybe point out if I'm missing anything, but those are the two main ones for physician ownership. As far as transparency goes, I don't know, other than Victoria Spartz. She is a leader in this, and she was involved with the Healthy Futures Task Force. So we have people on board that are supporting these concepts as well. And I might add, I don't want to beat on one side or the other. It's not one flavor or the other. There are Democrats now who are realizing that the Affordable Care Act is flawed. They know that we need to make things better, and there's much more open-mindedness now, especially with the president, and suggesting that we need to work on consolidation. But we have a big hurdle to get over to make this come to reality. So I would say, pick up your phone, get on your email, and start sending your legislators exactly this information. We need to repeal the ban on physician-owned hospitals. We need better transparency of healthcare costs. We need to change the inequality that exists in the site non-neutrality issue. These are things you can just say in 1 or 2, 3 sentences, and they'll know that you're on board and that you got it. And when they start hearing that, then they start listening. But if they're not hearing it, they will continue to bow to special interests.
What we'll try to do then is Free to Care will have a call to action, and we'll have a lot of these things listed in that call to action, and we'll send an email to everybody who's been on this so that they can support the efforts of our groups. I want to say on transparency, Free to Care is a bipartisan group. But even in transparency, that there's been bipartisan support and there's been bipartisan opposition as well. Many people on the right are fiercely opposed to hospital price transparency and price transparency at all because of they don't feel the government should mandate that. So they need to hear our voices. Our elected officials need to hear our voices. They need to hear your voice. So with that, I'm going to say, gentlemen, thank you so much for your time, your talent, your expertise. I really do appreciate it. Based on the feedback I'm seeing in the chat, I think we may need to do this again, especially as more is developed in terms of legislation and things happening. So perhaps next year, I'm already calling it. But again, thank you so much. You've been excellent. And thank you to those that have sat through this hour long. I'm sure for many of you, it's been your lunch period. So grateful for your interest and for your attention today, and look forward to the emails and to the calls to action, because